some water. Tim's a physio trained in London, qualifying in 1979, gosh. After spending some time in the NHS, he's now a professor at the University of Hearts. He lectures extensively on this topic. He's a fellow of the CSP. We're very lucky to have him. I'm delighted to have you, Professor Tim Watson.
Thank you very much, and good morning. How to follow Lorimer? No idea. It's normally me playing the ham up first, and somebody has to follow me. I got the dog slot, so no, hey, we'll give it a go. I'm absolutely, completely an imposter. I'm not MACP. I'm not a pusher and shover, wobbler and rubber. Well, I am, but I don't claim to be any good at it. I chose the wrong bit. I chose electrotherapy, electrical stim, and ultrasound and stuff. But hey, at the time, I thought that was pretty hot. Bum choice, Tim. So I also spend a lot of time looking at tissue repair, and that's luckily what they've asked me to talk about today. And I'm trying to lay, I don't pretend I've got all the answers. I think there's some really interesting stuff here. I'm presenting it. I think it's really interesting, and I think we're really missing a trick. We're really missing something we can sell. I don't mean financially, something we can promote. Have a look, see what you think. I've got a number of things to have a look at, and let's see, I've got no idea which way to point this. So we'll have a look a bit about inflammation, we'll have a look about how it's part of repair, and we'll have a look at some core components of it. That's Physiology 101, I'm not going to bore you too much with that. I think there's a really important common theme running through this, is that when you do therapy, when you do intervention, and whether that is manual therapy or exercise therapy or mechanical loading, or indeed some of the electrophysical stuff that I'm more involved with, it has an effect on that inflammatory process, and part of the mechanism of the effect of therapy is almost certainly mediated in this way, and that's what I'm going to try and explain. This is very reductionist. I know this is reductionist, and the people before me have been talking about the biopsychosocial model, and I absolutely 100% subscribe to the biopsychosocial model. I'm not knocking it at all. All I'm saying is that at some point, when you do something to the patient, it has an effect. And there must be something that links your doing to the effect, which is the outcome. And from way back, doing my doctorate, 25 years ago now, I was looking at that because that was what I was trying to measure. How, in part, how do we have this effect? So that's what I'm going to try and have a look at. This kind of picture we've seen before, sorry for those of you who've seen it from me before, this is the classic kind of phased sequence of repair, and inflammation's in there. Inflammation is in there as one of these phases of repair, but this is not how the body does it. In terms of the body's capacity to run through a repair sequence after tissue damage, the body doesn't say, now I'm going to inflame, stop, now I'm going to proliferate, stop, now I'm going to remodel, I don't know what it is, but it's the last thing and it's in green. And yeah, that's not how the body does it. From the body's perspective, this is one continuous sequence. We divide it up. We chunk it up into the inflammatory phase and the proliferative phase because it's just a way of making some pretty hairy stuff understandable. Now, my focus today is on the inflammatory bit because that's what they said. Look, Tim, just stick to the inflammatory bit. I'm actually going to link them together, but hey, it's too late. I'm up here. They're not going to stop me, I don't think, Chris. So therefore, I will focus on inflammation, but I'm going to try and spill it over and massively show how these are integrated. And the reality of what you're dealing with is a continuous sequence of events, and where you're interfering is some way down that sequence. The other thing that's important, I think, in the therapy world, that's just my focus, is that in the therapy world, we actually get a very skewed view about this whole sequence, especially the inflammatory bit, because an awful lot of the patients you will get to see, routinely, I get to see routinely, day in, day out, are not the patients in whom this is all going stunningly well, because they're the ones who least often actually get to see you. The ones you most often get to see are the ones in whom it's all going wrong. They're the ones you most often see, and therefore we do see inflammation 6 weeks, 8 weeks, 10 weeks down the line after an injury. It's not supposed to be there 6 weeks, 8 weeks, 10 weeks down the line. But that's what we see day in and day out, because that's what happens when it goes wrong. And therefore, don't forget, your clinical exposure to the inflammatory event is massively skewed by the population who turn up on your treatment couch. There is a normal sequence, if we just dare to dive back. There is a normal sequence, and the normal sequence is that the inflammatory process is there, it's normal, it's necessary, we're just going to look at. It does a job, and you're supposed to move through that process and move on. Because we see a lot of patients with a lot of things where it's gone wrong, then don't be surprised in your clinical world. There's definitely a battery change needed here. In your clinical world, don't be surprised when you see this stuff going on for weeks and weeks out of sync. It happens. Okay, so look, I'm not going to do inflammation in first year physiology terms. We've all seen these kind of maps. I'm sorry, I should have said at the beginning, that coming up is a zillion load of references. On the website, the address was at the beginning, the address is at the end. On the website, I have put a PDF file up of every reference I'm using. So if you want to download all the references, please don't feel obliged to scribble, or you can take pictures of the screen if you want to, but you don't need to. It's PDF, download it, grab it, if you want to catch up. We've all seen this kind of picture. This is the kind of, this is not very complete, but it's the Enid Blyton model of inflammation. Noddy and Big Ears have a wander around the inflammatory process. And the essentials of that are what we've all learned about. What's important, I think, about the inflammatory process is that the inflammatory process is both normal, it's absolutely necessary, and it's controlled by a range of chemical mediators. And that's where we're heading off next. Because if you've damaged any kind of tissue, whether that's neural tissue or muscle tissue or ligament or joint structure or whatever it is, bursa, fascia, whatever, inflammation will be an absolutely normal part of that repair sequence. You are supposed to have an inflammatory process. It is not your enemy. It is not a mistake. It's massively controlled by the body. It's controlled extraordinarily well in most circumstances by the body. And if you did not have an inflammatory sequence leading the way down through the repair process, your repair would go wrong. It does go wrong. And therefore, the common perception of our patients is that the inflammation is a mistake and we've got to get rid of it. And rubbing in something to an inflamed bit gets right to the point, according to the TV adverts. Not quite sure how they get away with some of them adverts, but the patients believe that inflammation is bad and inflammation's got to be gotten rid of in order to recover. Getting rid of the inflammation will make you better. That's actually not the truth. The truth is that the inflammation is a normal component of repair, and if you don't have the inflammatory stuff leading the way, your repair will be disturbed. There's also massive links we're going to pick up on that link your inflammatory stuff to what comes next, which is the core repair message. The fact is that that sequence is controlled massively by a range of chemicals, and I want to have a look at those, not because I'm a chemist, not because I believe you need to be a chemist, and we've already heard about interleukin 4, I'm going to throw a few more in the pot here, but because this, I suspect, is part of how your therapy works. Whether you're doing manipulative therapy, whether you're doing massage, whether you're using exercise, whether you're using ultrasound, whether you're using traction, we heard about that earlier, or whether you're using some kind of combo package of lots of these things, you are influencing this. And I think this is potentially a really powerful tool. And it could be potentially something that unites, it ties together our different bits of therapy. I'll tease you with that one. Okay, so we're not going to do a massive great list of chemicals, though I put some lists up there in just a moment. Some of these chemical mediators, and I'll use the term chemical mediator just to encompass the whole of this stuff. There's loads of them, all right? Some of them are pre-formed, top left. They're pre-formed and stored. They're just sitting there waiting for the stimulus, and then poof, they're off. They're released. Some of them are plasma sourced, especially things like the complement cascades down the bottom there, and some of them over the right-hand side, some of the ones that you might think of as the bad boys, prostaglandins and stuff like that, and some of the other really exciting ones from my point of view are synthesized in response to a stimulus. But there's more than that, a lot more than that, all right? Some of those, and I'm not going to do too much on pain. Lorimer's and lots of people around here, but Lorimer's just done a supremely, great explanation about some of the issues in pain that matter. I'm not going to try and compete with this chemical stuff at the pain level, but some of the stuff I'm talking about has massive overlaps with pain, and obvious ones like the bradykinins. The bradykinins are released from, it's a blood flow one, isn't it? It's a plasma source. From my point of view, they have really significant effects on things like vascular dilation and on things like vascular permeability. That's really important for inflammation and proliferation and healing. But they also, as you well know, they also irritate nerve endings, therefore they are going to change pain perception. You can't divorce these cytokines from their healing role and the cytokines, the same chemicals, the same mediators, from their role in pain and pain perception. I'm going to concentrate on the healing role because that's my field rather than the pain stuff. There's a lot of these mediators, and I'm not trying to do detail. There's a lot of them. There's massive backup. There's massive overlap. So if one of these mediators fails, trust me, there's at least one, probably more than one, that are going to back up the system. This is not a system of mistakes. This is a system of incredibly clever control which manages how you and your damaged tissue gets through its sequence to get it as mended as you can. How you as a therapist are going to influence this system is real world, which is where we're heading. Okay, so don't worry about that. And that's not a complete list. That's just some of these families that you may have heard about in passing. The kind of things that you're thinking, yeah, turn the page, really not fussed about this one. So the interleukins, well, when I was doing my PhD work, I think interleukins existed. People would talk about interleukin 1, maybe interleukin 3. I think interleukin 33 was the latest one I've seen identified. This stuff changes every week. And if you don't know the difference between interleukin 1 and interleukin 4 and interleukin 6, your clinical practice world is not going to come to an end. If you don't know the difference between the interleukins and the matrix what are them things up the top right, MMPs? Is that going to change the way you treat your next patient? No. But I'm going to try and illustrate that you influence that chemistry. And when you do therapy, when you do intervention of whatever kind, you are playing with that chemistry, playing in the therapy sense. Vascular endothelial growth factors, fibroblastic growth factors, prostaglandins, transforming growth factors. Some of those you'll be familiar with, some of those you'll have heard of, some of those you'll be thinking, that's not for me. Tumor necrosis factors, we don't do tumor treatments. You play with tumor necrosis factors because tumor necrosis factors are out there and they do a job. And when you do therapy, you change how they behave. Okay, so each modality, each mediator has got a pathway, and I've got pictures which I've tried to draw, which are fairly pants compared with these. So I've used some pictures from other people. These guys, SA Biosciences, they make their images available. They're prettier than my images. They're more accurate than my images, and therefore, with permission, I'm using them. If you ever need diagrams about how these chemicals work, that's a great place to go. Anyway, tumor necrosis factor. You think we're not fussed about tumors. Tumor necrosis factor, there's a pathway, this is the pathway inside the cell, is a pro-inflammatory cytokine. In other words, a chemical mediator which drives, which stimulates, which promotes, which advocates the inflammatory sequence. There's a lot of members of the TNF family, but it includes signals that drive proliferation. Proliferation is what's going to come next. So chemicals which are involved in the inflammatory sequence are not only driving the inflammatory sequence, but they're instigating the move into proliferation, which is where you do your fundamental repairing. If you turn off inflammation, then you turn off some of the drivers that push this tissue down through its repair sequence. Not so clever. There's others, okay, and there's lots of diagrams here. So the fibroblastic growth factors, there's lots of fibroblastic growth factors. Another pretty diagram, again, not from me. Stimulates angiogenesis. The angiogenesis, absolutely critical, as you'll see when I try and do a build-up slide in just a moment. in the therapy world, we quite often talk about angiogenesis and neovascularization as being a bad thing, certainly in relation to tendinopathy, but actually angiogenesis is an absolutely key process in the sequence of repair. You need angiogenesis, you need the chemicals that drive angiogenesis, and your therapy, your intervention stimulates the release of these chemicals. That's the really important thing. And we can go through, and if we weren't coming up to lunch and if we weren't running out of time, I'm completely sad. We could spend hours talking about this stuff, but we haven't got hours, and you've got lunch coming up, and you probably don't want me to talk for hours about VEGF and what's the differentiation between angiogenesis and neovascularization, but it's out there, it's real, it happens, and we've got evidence for it. Okay, so let's try and make this a bit more therapy relevant. These guys, not a new paper, but just as an illustrator, these guys, Smith et al., back in 2008, had a look at the inflammatory process in muscle after injury. And they basically set out to say, okay, how many different mediators can we find for which there is real-world clinical related evidence of activity? And they found 72. I did a more recent version of that kind of study, and I was getting around about 100. So I can find, without too much trouble at all, at least 100 different chemical mediators which influence the inflammatory sequence in muscle after injury. Those mediators are not there by mistake. Those mediators are there on purpose, and when you do therapy, you're going to influence their release. So let's try and tie that up a bit, because trying up the intervention, if not, it just becomes a cell biology talk. Pretty pants, pretty boring, and not what you want to hear. All right, so I'm going to try and keep this with a therapy link. There's a growing body of evidence that says that when therapy is applied, intervention is applied, you have an effect on these chemical mediator families. I'm strongly making the point that this is an effect which is additional, if you like. I'm not trying to say that manual therapy and exercise therapy are only effective because they stimulate these chemical pathways. That would be absolutely, that's rubbish. All I'm saying is that this is an area where there is a growing body of evidence, and that evidence gives you an additional mechanistic pathway. And that doesn't destroy the biopsychosocial model. It doesn't destroy whatever beliefs you've got about the effect of manual therapy, the effect of exercise therapy. It's an additional explanation role. So, for example, if we take those inflammatory mediators and put them all in one pot in the center there, we know, and I'll have a look at some evidence in just a sec as we go through, exercise, mechanical stress, manual therapy, however broad, and I appreciate the comments made early this morning on this, however broad you want to take manual therapy, it has an effect on those mediators. So does massage. So does vibration. And then we move into the realm where I'm more comfortable, over in the ultrasoundy, lasery, electrical stimmy, shockwavy world. And I know that's not the focus of today's talk, but they all have an effect on these mediator systems. And I rather suspect if we wanted one thing that could unite, could marry up those various therapies, the mediation system might just be the baby. These are the references that are all on the download sheet. Please, by all means, write down what you like. You're never going to get them down in time because I'm going to go too fast, all right, with the minutes we've got left. All I'm saying is I'm not just making this up. This comes from a very large body of evidence. These are not the only papers I can find on the relationship between exercise and these chemical mediator systems. It's a selection. There are loads more on the reference sheet. So, for example, we've known for a long, long time that patients who do undertake the exercise have a better outcome than the patients who say they're going to do the exercise but don't. That's a clinical norm. We all appreciate that. When I was giving patients exercise, when I was working full-time clinical, I did not know that a patient after a total hip replacement and me getting them to do their exercise, I didn't know that was stimulating their prostaglandin C1 alpha. Well, I'd never even heard of prostaglandin C1 alpha. No? But the exercise I was getting the patients to do was stimulating its release, as it was the transforming growth factors, as it was the COX-2s, as it was the interleukins. It's not just exercise. Mechanical stress. This is not the manual therapy stuff. This is mechanical stress. You mechanically stressing the tissue, the patient mechanically stressing the tissue, loading. So lower limb injury, apply load. Something as simple as that, we know stimulates the release of some of these mediators. Massage, manual therapy, I guess in your home territory, we know, and these are not just animal studies, these are studies from clinical studies, from healthy human studies, from patient studies, as well as lab studies, as well as animal studies. I've tried to keep these as clinical as I can in terms of relevance to you guys. So when I clinically was using massage as an intervention, I thought massage did the kind of things that I was taught massage did when I did my training, which is in the mid-70s. That's the 1970s. I'm sure most of my students think it was the 1870s, but it was the 1970s. And we were told, massage works by you're pushing fluid from the periphery, you're mobilizing tissue, and I'm not knocking any of that stuff. All I'm saying is, in addition to whatever mechanical effects your massage having, whatever gross physiological effects your massage is having, and I believe they're out there and they're real, all I'm saying is your massage and your manual therapy are also stimulating the chemistry of the inflammatory repair sequence, and the evidence is backing that up, as does vibration. Vibration, a bit trendy, certainly whole body vibration, really trendy in the gym, doing exercise on a vibrating platform. Actually a big body of evidence that says it's real and it makes a difference, but certainly in terms of the chemistry, it works, as does local vibration. And then we get into the realm where I get all excited and animated, which I'll try and keep away from today, but things like ultrasound. Ultrasound is stimulating the release of the chemicals, which are the same chemical families that your vibration is stimulating, which are the same families that your manual therapy and your massage are stimulating, which are the same families that your mechanical stress is stimulating, and exercise. There's no fundamental difference in how these chemical families are stimulated by different interventions. And therefore, ultrasound may be seen as passé and passive and not part of your world, but actually the chemistry it's stimulating is the same old baby, as is laser, as is electrical stim, as is, I think that's the last one. Yeah, that's the last one. I could do pages and pages of that because I'm sad. But if there's one thing that unites our therapies, it might just be this, which might just be interesting for the future. So let's have a look at a couple of example pathways before we run out of time and you run out of patients' good lunches on its way. So let's look, break the rules, go shockwave. Okay, chronic tendinopathy and shockwave. So we know that you can have an enhanced tendon response if you use shockwave in a chronic tendinopathy. The clinical trial evidence out there would support that intervention. And that's not using shockwave instead of manual therapy. It's not using shockwave instead of exercise. The evidence out there categorically says use shockwave in conjunction with, and you will get a better result. Anyway, that's another talk for another day. We know that's achieved by a pro-inflammatory stimulus, as is your eccentric loading, as is your other intervention. We know the list is almost certainly longer than that, but that's the list I've currently got. So we know that if you apply shockwave as an intervention, it will stimulate at least interleukin 6, interleukin 8, MMP2, MMP9, VEGF, TEGF beta, and what the dude is that one on the right, H1F1, HIF1 alpha. It doesn't matter. It's actually hypoxic inducible factor 1 alpha. It doesn't matter. It's another one of these chemical mediators. You are doing therapy. We know the therapy has an effect. All I'm trying to do is to fill in the gap in the middle. How does your therapy achieve the effect we know it has? And this kind of middle ground appears to be common. If we looked at exercise, this is exercise and this is exercise and mechanical loading, and it's the effect on bone healing. So if you've got a patient with a fracture, we've known for a long, long time, even back when I did my training, we've known for a long, long time that the patients who are active within limits have a better outcome of their fracture repair. The ones who just lie there waiting for the fracture to mend actually take longer to mend. The ones who overdo it tend to get themselves in big doo-doos and they go right back to the beginning and start all over again. And our job in the therapy world is to try and get them to do something, isn't it? I don't know why I'm telling you this. You know this. We're trying to get them to do something, and we know the patients who do something but not too much, get a better result. We're trying to hit that middle ground. All I'm arguing here is that in addition to whatever else the exercise is doing, in addition to everything else the mechanical loading is doing, we know that those interventions are stimulating, enhancing, promoting the release of chemicals, which is the mechanism by which that result is achieved. And in this one, it's a similar group, but it's slightly different. This one's prostaglandin E2, TGF-beta, MMPs again, interleukin again, calcium and nitrous oxide again. The details of that are not what I'm trying to convey today. I'm trying to convey that we've got a potential a gap filler. We know treatment X has effect Y. There must be a mechanism by which treatment X achieves effect Y. It's reductionist, it's bioscience, but I'm trying to suggest we've got a gap filler, and the gap filler is potentially the chemistry. So this is the ultrasound stuff again. This is ultrasound and fracture healing. We know ultrasound stimulates fracture healing, and this is lipus. This is not your regular ultrasound. This is low-dose ultrasound. Over on the left-hand side, the pink range. The pink range are the mediators that we know the ultrasound stimulates. The right-hand blue stuff is the effect we know that stimulation is having. This is not a mystery. This is a gap we can fill, and I find that really encouraging, not because of the ultrasound bit, but because it gives us a mechanism which explains, at least in part, how our therapy is potentially working. Mechanotransduction, probably much more comfortable ground for you guys. Mechanotransduction's been around for a long time. We know it's been around for a long time, but it seems to be making a bit of a comeback, and there's been a number of papers. This was fairly recent, done from 2016, a couple of months back in the, I think that was from Physical Therapy, looking at it again. And that's, it's been out there. Scott from 28, Ingber back in 23, Wang and Lee, great paper from 2010. They're all looking at this same issue. It's not just me. I'm not just making it up. I'm not just here to entertain you in the pre-lunch break. This stuff is real, and with tendinopathy. So, 2 slides just to try and tie this up before we run out of time and you run out of the will to live. Let's imagine, firstly, that your physical stimulus, whether that's exercise or manual therapy or massage or traction or loading or stuff, clever stuff, your physical stimulus has somehow got to get a cell to react. And we're pretty sure, in common with all those interventions, the pathway is something like this. The physical stimulus instigates a change in how the cell membrane behaves. That effectively lets more calcium ions in. That gets the inside of the cell pretty wound up. Probably intracellular CAMP is the pathway, and that ends up in the cell doing more stuff, releasing chemicals. So that at least is explaining how your physical stimulus is achieving a cellular upregulation. Let's try and work this one backwards and make this one clinically relevant, all right? So let's imagine we've got some damaged tissue, and let's imagine we're going to repair that damaged tissue. We're going to repair that damaged tissue with a mixture of collagen and ECM, extracellular matrix. We know that comes from the fibroblasts, all right? That's not a secret. We know the fibroblasts are stimulated by particular chemical mediators. They're probably the most potent fibroblastic stimulators I can find from the evidence base. And we know that those mediators are released by, in this case, platelets and macrophages during the inflammatory phase. So your intervention in the inflammatory phase stimulates those cells to release those mediators to stimulate the fibroblast to make the thing mend. Pretty damn clever, all right? We also know that in order for a fibroblast to do that job, it needs oxygen. We know that increasing the oxygen delivery to the damaged tissue is critical for repair. We know that that is achieved in the physiological sequence of repair by stimulating angiogenic events. I'm sorry if this is junior school stuff that you've all done so many times. It's kind of, just bear with me. We know that angiogenesis is stimulated by chemical mediators. We know where those chemical mediators come from. And here's the blaster, from my point of view. We know that exercise therapy, manual therapy, mechanical stress, and electrophysical agents stimulate those cells to release those mediators to instigate that effect. That is neat. In my humble opinion, that is neat. Because we now know not only that manual therapy makes a difference to repair, but we've got a potential pathway through which that can operate. And personally, I find that really quite exciting. Okay, 28 seconds. Let's see if we can do the last slide. No, but we'll give it a go, all right? I think historically, and bear in mind that I'm an ancient old creature, in some senses anyway, and when I learnt my massage and when I learnt my exercise therapy, and I was reading as much as I could, I wasn't a slouch, I was kind of reading as much as I could around the subject. Everybody was explaining the effect of those interventions in terms of mechanics, in terms of gross physiology. When you do manual therapy, you push in this direction with this oscillation, and it does this. When you do this exercise with this number of repetitions at a 10 RM, it does this. And I'm absolutely not knocking the mechanics explanation. I'm not knocking the gross physiology explanation. I just don't think they're not enough to explain the reality. And therefore, I would argue, and I've only picked on a little bit of this today, that yes, you're having a mechanical effect. Yes, you're having a gross physiological effect. Yes, you're having a neurological effect. Yes, you're having a chemical effect, which is where I've been dabbling this morning, and the bit I haven't touched on today, but you're also having a bioelectric effect. And somehow, it's that combination of treatment effects that at least is a more comprehensive explanation as to how your intervention has an effect on repair, and patients genuinely do have a better repair. Not because you've changed it, because you've helped it to happen right from, my argument today, the inflammatory phase. Okay, at the end of the day, that's pretty much the summary of where we were. If you have any inclination to chase up any of those references, they are all available as a download on the website. I'm not saying you have to. All I'm saying is I said they were up there. They are already up there, if that helps. Thank you very much. Chris?
That's great, Tim. Thanks very much. We have a couple of questions that have come through for you. We've got time for a couple if you're okay. So there's a question about...
Choose nice ones off that list.
All right, well, there's a couple here actually that have been answered as you've gone on. But so do you think the use of non-steroidal anti-inflammatory tablets, medications, promote the development of persistent pain?
Potentially, yes. I mean, I think there's a big relationship between these chemical mediators and pain, which I touched on but didn't really cover in detail. I think NSAIDs, potentially, and there's several hundred papers out there, NSAIDs have the potential to slow down the repair process. And it's not that NSAIDs are bad, but if you use NSAIDs at sufficient dose when the tissue is damaged and needs to go through a repair sequence, it inhibits the repair sequence. And I'm pretty sure somewhere in there's going to be a relationship between long-term NSAID use, potentiation, slowing down of recovery, and persisting pain. I'm pretty sure that cycle is in there, and I wouldn't be surprised at all if it was in some way related to that. Targets like your prostaglandin E2. Prostaglandin E2 is a chemical which you need to drive repair. Prostaglandin E2 is a chemical that's shut down by the use of NSAIDs. So our NSAIDs are shutting down the chemical which is a driver of the repair sequence. Not so smart. And there's got to be a relationship. I don't understand it. You guys might. I don't understand all the implications, but it's out there.
Okay.
That's a pathetic answer, but it filled up time.
All right. Well, here's a long question for a long answer.
It wasn't. That's a joke. I'm not just trying to fill up time. Go on. Give me another one.
This is a tough one to finish on. So, taking into account the biopsychosocial model.
Yep.
What is the influence of psychological factors, the interaction with patient and therapist on inflammation and tissue batteries?
I don't know whether the psychological elements of the biopsychosocial model have a measurable effect on chemical mediator release expression. I'm absolutely sure that the psychological impacts psychological influences make a big impact on therapy. From what Lorimer was saying in the previous one, just look at some of those results. I wouldn't actually be surprised if the psychological elements had an effect on chemical mediator release. I've never seen any direct evidence in the periphery, in tissue healing research. I've never seen any direct evidence that says so. I would not be shocked if that evidence existed. I wouldn't be shocked if it existed. I would almost expect it to exist, because we know that psychological influences have a measurable effect on healing and recovery. If the chemical mediators are the way in which that is achieved, it wouldn't shock me if the psychology and the mediators and the repair were in some way tied up. I've not researched it. I can't remember ever seeing any direct research, but it wouldn't shock me.
Lovely. Okay, thanks very much, Tim.
Okay.
That's the end of the session, folks. If you have the time, do go to the end of the abstract and rate the session. And if we can head off for lunch now, do have a look at the exhibitors and the posters, and we'll see you back after lunch in your breakout sessions.